There.
You switch them.
Does that light interfere with the camera?
Okay. All right. Cool. Thank you. All right. Awesome. So I'm Dr. Gilo. Today we're going to be talking about cirrhotic management. So something that we see kind of more frequently in the ICU, and so it's kind of a good idea to know that their physiology is a little bit different, as well as what we can actually do that actually makes a difference. So approximately 26,000 patients in the U.S. have cirrhosis, and that will require ICU care. The in-hospital mortality for these people is greater than 50%, and the mean length of hospitalization is 13.8, so greater than the average patient. And then the total charges alone associated with this are greater than almost $3 billion, and that data is actually old. That was from like 2016. And ICU mortality rates are associated with cirrhosis have remained basically essentially unchanged for 20 years. So whatever we're doing is really not making that much of a difference, and these patients are still proceeding to mortality. So exactly how much do you drink? How much will cause cirrhosis? So it's estimated that the development of cirrhosis requires, on average, the ingestion of 80 grams of ethanol daily for 10 to 20 years. That's ethanol alone. That's not 80 grams of booze, so that equals about 1 liter of wine, 8 standard-sized beers, so 8 12-ounce beers, or half a pint of hard liquor each day for 10 years to get to be a cirrhotic. And the pathophysiology is pretty interesting. So it's irreversible chronic injury to the hepatic parenchyma. You get extensive fibrosis, you get hepatic architecture that gets distorted, and then you get this formation of these regenerative nodules that you see here on that first slide. So these next two slides are from the pathologist that did our teaching in medical school, pathguy.com. And so liver failure, some of the signs and symptoms are encephalopathy, carotid enlargement, spider angiomas, muscle wasting, right? These people get purpura, asterixis, the flopping of the hands, testicular atrophy, mild edema. You can get palmar erythema, gynecomastia, as well as feeder hepaticus, that fruit smelling breath. And so these are also oftentimes associated with portal hypertension as well. So this is the cirrhotic that you may see in the ICU, right? Big belly, he's got caput medusae, there's extra venous dilatations on the abdomen. May have some hemorrhoids, right? That's all from venous engorgement. Ascites, hypersplenism, as well as a patient with varices. So can be associated together. So these patients' issue is, right, they're physiologically deranged at baseline compared to the majority of the trauma patients or general surgery patients you may see in the ICU, right? So acute deterioration of their cirrhosis may be associated immediately with multiple organ failure. These patients are kind of walking the razor's edge to begin with, based on their physiologic state, and then something else, their trauma, their general surgery issue sets them off. So even viral infections, hepatitis, alcohol, they get a GI bleed, right? Or even just hemorrhage from a trauma can set their whole system off to where we're not able to maintain blood pressure, or we lose physiologic capture. Less common, ischemia or drug-induced hepatotoxicity. So what I think is interesting is patients with cirrhosis currently admitted, who have been admitted to the hospital within the previous 6 months, they have a higher mortality rate compared to patients who had not been hospitalized. So kind of similar to, with gunshot wounds. If you have been shot and you get shot again, your increased risk of mortality, right? So 78% mortality rate if you've had hospitalization for cirrhosis 6 months prior versus 34. Another big thing which is in our guideline is as the number of failing organ systems increases, so does the mortality, right? Makes sense. So as they begin to progress rapidly into organ failure, their mortality increases. So if you have 2 failing organ systems in a cirrhotic, irregardless of the rate of mortality from that organ system that's failing or their injury, that rate is 55%. Whereas if you develop 3 or more organ failures, those patients have almost 100% mortality. So we're going to go through a couple of the organ systems that fail. So liver dysfunction, right? Sepsis and systemic inflammatory response usually result in acute deterioration of the liver function. What happens is you have tumor necrosis factor A, interleukin-6, and other markers of activation of the immune system. They play a key role in hepatocellular microcirculatory dysfunction. This results in high portal pressures and reduced hepatic blood flow, which further worsens their liver failure. And as you know from our general surgery rotations, right, the liver is the first organ to take a hit in the abdomen. First organ with abdominal hypertension to take a hit. So knowing that these patients already have a deranged liver, and that's the first organ that'll take a hit, that's very important. Renal dysfunction, and we'll talk later in the lecture about renal dysfunction and hepatorenal syndrome. And it's the most common organ dysfunction that they gain after their liver dysfunction. It's in the four main types: HRS or hepatorenal syndrome, and then there's types 1 and 2, which we'll talk about. Hypovolemia-induced, kind of ATN, parenchymal disease, and drug-induced. And when looking at the literature, bacterial infection is a major risk factor for development of any type of renal dysfunction in a cirrhotic, especially hepatorenal syndrome. Adrenal insufficiency. So 51 to 68% of patients with cirrhosis will be diagnosed with adrenal insufficiency while in the ICU. It's associated with an increased mortality compared to patients without adrenal insufficiency. But we'll talk later on that recommendations are not that we would replace it unless they're hypertensive. Pulmonary-wise, right, acute respiratory failure, pneumonias, acute lung injury versus something that happens from the consequences of their cirrhosis, right? Portal pulmonary hypertension. They have bilateral pleural effusions, hepatopulmonary syndrome, which we'll talk about. Those all can demonstrate that you're beginning to have respiratory failure from your liver failure. Basically, this is the same thing that we have been talking about. It's an exaggerated inflammatory response, and it's coupled with immunocompromised state, and those patients can get a lung injury. Decreased thoracic compliance. Talking about that in a cirrhotic, we're talking about edema on the outside of the chest wall, as well as thoracic compliance being dealt with a large amount of ascites leading to intra-abdominal hypertension pushing up on the diaphragm. We can't expand the lungs because there's no place for them to go. In addition to all this, just with the lungs, you have to think about aspiration pneumonias, right? These people many times have altered levels of consciousness. They may be alcoholics who are withdrawing, so they may have swallowing dysfunction as well. They have gastric stasis from their ascites. They may have intra-abdominal hypertension or increased intra-abdominal pressures, their ascites, or ileus from infection. And these can all lead to aspirations. So hepatopulmonary syndrome, our medical colleague here probably knows much more than we do because they probably deal with it on a greater basis. But basically it's the formation of microscopic intrapulmonary arteriovenous dilations in patients that have cirrhosis or liver failure. It's basically due to increased liver production or decreased clearance of vasodilators. And INO is thought to be one of the main ones. And so then dilation of the blood vessels causes overperfusion relative to ventilation, leading to ventilation-perfusion mismatch and hypoxemia. Kind of like patients that get pulmonary contusions. Basically, this is a microscopic intrapulmonary formation by these vasodilators to form dense lungs that are poor at oxygenating. In addition, cardiovascular, right? These patients are hypodynamic and they're kind of in a prolonged vasodilatory state. They have small decreases in arterial tone on these patients. When you take care of them, you'll see they dramatically decrease the circulating volume and precipitate hypotension, right? They have these huge fluid shifts from removal of the fluid from the ascites, low protein in there. They also may have cardiomyopathy with a low normal ejection fraction. Many of them have diastolic dysfunction or just delayed repolarization syndromes. Getting into cerebrovascular, hepatic encephalopathy, right? Elevated ammonia levels, leading to them not being able to mentate. And then activation of the inflammatory mediators, such as like activation of the cytokines, can enhance the effects of the ammonia, which so it's even more important to get that off That's why, we'll check that in the ICU. Then you may get disturbances in neurotransmission, injury to astrocytes, energy impairment, brain edema. Brain edema is quite often seen in cirrhotics. So many times you'll see us, if we have a cirrhotic who we check, an ammonia level on, it's not elevated, but they're not waking up. They have no history of subdural hematoma, but they just had a, bowel resection and became septic. Many times they may develop brain edema, which then is what's causing them to have the low GCS. And as always we know, right, coagulation abnormalities, the liver is primary function is for synthesis of the coagulation factors. So you may get impaired synthesis of that or increased consumption. I'll talk a little bit later on about how just because they have an elevated INR doesn't mean that they're therapeutically anticoagulated. There's many papers out there that will show that those patients still will clot off everything. We've actually had patients do that, clot off their mesentery, throw clots from even having an elevated INR. Vascular disease, right? Extrahepatic portal vein thrombosis and ischemia can be common. Basically, sepsis superimposed on hypovolemia leads to hypotension, and basically the liver becomes further ischemic. You get stasis, and then even with the elevated INR, if the clotting factors aren't in abundance, right, we can end up clotting off our portal vein. So here's kind of a flow chart of how we deal with it in the unit, and we have a guideline that's kind of based off of this. So basically, it's going basically by A, B, C, D, similar to ATLS, with airway or being hepatic encephalopathy, right? GCS less than 8, intubate. B, hypoxemia. Consider your etiology. Check your FiO2, whether or not they need to be ventilated. C, blood pressures. We talked about the vasodilatory effects and cardiomyopathies. And so you just go down your algorithm, and that should be able to help you maintain treatment for your cirrhotic patient. So, monitoring and hemodynamics, right? One of the best modalities is echocardiography. Provides a better assessment of ventricular function than using something like a Vigileo in the papers. It'll help us to see if they have a diastolic dysfunction, if they have cardiomyopathy. Pulmonary hypertension associated with cirrhosis, and a PA catheter may be required to help measure your PA pressures as well as your wedge pressures. We talked throughout about increased intra-abdominal pressure as a consequence of the ascites, and intra-abdominal hypertension, bladder pressures and intra-abdominal pressure should be maintained below 20 millimeters of mercury. And you can achieve this by large volume paracentesis with concomitant albumin replacement at 6 to 8 grams of albumin per liter of ascites removed. The optimal mean arterial pressure goal is unknown, but if we're managing all this based on intra-abdominal pressures, we have to assume that we want a mean arterial pressure of at least 60, depending on what our intra-abdominal hypertension numbers are. Vasopressors such as norepi can be titrated to achieve MAPS greater than 65 after fluid resuscitation, all depending on your resuscitation parameters. So ascites, it's great for the worm Ascites, bag-like. You can see large bag-like belly being drained. Another thing that we use less in surgical critical care, but more in medicine, is the serum ascites albumin gradient. Basically, this is your albumin serum in grams per deciliter. And you're subtracting your albumin in your ascites per grams per deciliter. And you're looking at basically numbers like 1.1. So less than 1.1, you think biliary leak, nephrotic syndrome, someone with pancreatitis, tuberculosis. If it's greater than or equal than 1.1, you're basically then breaking it down to whether or not how much acidic protein you have. And the number there is 2.5, and then you kind of are breaking it down to whether it's cirrhosis or basically the patient has congestive heart failure or may have IVC obstruction. So fluid choices in hyponatremia. So this is based on the guidelines for cirrhosis on hyponatremia from Consortium of GI Physicians from 2018. And basically, 126 and 135, normal serum creatinine. You can continue diuretic therapy and observe the electrolytes. You don't have to water restrict those patients. I mean, they probably live in that sodium range. Sodium levels 121 to 125 with a normal creatinine. Currently, the international opinion is to continue diuretic therapy, but the opinion of the paper at that point was to stop diuretic therapy and adopt a more cautious approach, which we tend to do here as well. If your creatinine is elevated at that point, basically stop giving diuretics and get volume expansion, right? You're behind. If your serum sodium is less than 120, you should stop diuretics. And then management throughout the papers is controversial. It can be difficult because you're trying to decide whether or not you have hypovolemic hyponatremia, that you're going to require volume expansion with your colloid or saline. And you should try to avoid increasing the serum sodium by greater than 0.12 millimoles per 24 hours. So ascites. First line of a treatment is spironolactone alone, right? And this is for patients not in the ICU, not that have some other issue presenting, but patients as an outpatient. And you can increase that from 100 milligrams a day to a dose of 400 milligrams a day. If this fails to resolve the ascites, you can add Lasix. Some papers show adding Lasix alone, but you can add Lasix up to a dose of 160 milligrams a day. And that's a level 1A evidence by the same paper that talked about the treatment. In terms of paracentesis, this is something we'll more do on surgical critical care. Patient has intra-abdominal hypertension, doesn't have intra-abdominal injury, we need to offload the abdominal pressure. We can basically do that as first-line treatment for large or refractory ascites. This diagram here is showing kind of a Z pattern. So what they're doing is basically pulling the skin down 2 centimeters and then sticking the needle in while aspirating, obviously, if you go through the fat and then into the peritoneal cavity. And what that is doing is once you remove your needle or your chest tube that you're going to do to drain that fluid, once you pull it out, that skin should retract up and it changes the level of the hole so you don't get a continuous acidic leak afterwards, right? Because the last thing you want to do is then just have the patient point ascites out of the abdominal hole. And they recommend large volume paracentesis performed in a single session with volume expansion. So basically similar to a patient that was on the service last week where we had a paracentesis catheter in, but we had a stopcock on. So going routinely, draining the fluid off, get the amount of fluid off, then allow that patient to sit there with their own proteinaceous fluid and then replace that you have lost with albumin. So last slide we had 8 to 12, so about 8 grams of albumin per liter of ascites removed. That's, again, level 1B evidence. So airway pulmonary management, we kind of went through that slide before that showed the algorithm. Again, always GCS less than 8, intubate, or in the presence of active upper GI bleed, right? Esophageal varices, protect that patient's airway because you're going to have to put a tube of sorts in there to protect it or to stop the bleed. Low tidal volumes, as described for most things, right, to prevent lung injury. Many times these patients will require prompt tracheostomy based on mental status alone, right, hepatic encephalopathy, or even we talked about issues with pleural effusions versus issues with hepatopulmonary syndrome. Get these patients up, move them. And thoracentesis may not be necessary for all pleural effusions, but if it's preventing adequate ventilation, then go ahead and place small bore thoracostomy tubes in a similar fashion, kind of in a Z-like fashion or tunneled to prevent leak of acidic fluid once you pull that out. And then TIPS is recommended in select patients with refractory hepatic hydrothorax. So if we can't get those hydrothoraxes under control, decrease their portal pressures by having the patient undergo TIPS. Neural problems, right? We've all seen the patients with elevated ammonia levels. We get an ammonia level of 115. The patient's GCS is diminished. What do we do? So non-absorbable disaccharides, lactulose is our mainstay here, and we use that. And basically, data has showed no superiority superiority of these drugs over placebo. But I think we all can speak, but we like seeing the number come down. We like to make the patient euvoxemic, check all the boxes in the sunrise system. It decreases ammonia levels in the portal systemic circulation. You can do oral doses of 40 to 60 grams, and then we just dose it based to bowel movements. All right. You can also give oral rifaximin, and that's a non-absorbable derivative of rifamycin. And basically, that modulates gut flora. Basically, it can be used as a treatment of this as well. It's also effective as a secondary prevention in people with hepatic encephalopathy. Protein restriction when talking to dietary is not recommended. Normal diet in terms of protein is safe and nutrition is better for those with hepatic encephalopathy. Albumin dialysis or patients with MARS with severe hepatic encephalopathy is indicated. Basically, once you get to that point, you're kind of looking for anything to help them. And then L-ornithine and L-aspartamine, those act by providing substrates from ammonia metabolism. So if you have feeds that have those available or supplements, you can use those. Basically, the results have been inconsistent, not recommended by consortium of GI physicians, but something to consider if things aren't working. Preventing bleeding and control of blood. So tagged, basically, I know we've all seen the tag and the INR be different, and Dr. Smith will tell you treat the one that's abnormal. But tag in cirrhotics has been found to be improved in terms of guiding to resuscitation compared to INR in a cirrhotic. Routine correction of coagulopathy abnormalities in the presence of active and not active bleeding is not indicated. So if they're not bleeding, if their coagulopathy is still there, you probably don't need to treat it unless you're going to intervene in some point or intervene in some way. Isolated abnormalities in the INR with a normal PT and a normal tag R time do not require correction. If you're worried that the patient is vitamin K deficiency as part of their coagulopathy, you can give them 2 milligrams of vitamin K for 3 to 5 days and see if that'll help. That's in our guideline. We do that. Obviously, massive acute hemorrhage should be managed with a 1-to-1 transfusion ratio. All right, but in the presence of bleeding, you want to try to keep your platelet level greater than 50. And these are highlighted because these are some things you have to think about with a cirrhotic, right? They may have a qualitative platelet dysfunction, so you may have to give them DDAVP, right? And so they may be going into hepatorenal syndrome, so give them DDAVP for that. TXA is indicated when bleeding for cysts, despite the correction of your thrombocytopenia and your clotting factors in the absence of DIC. If the PTT is excessively prolonged, you can use protamine, and that you can use that even in the absence of heparin therapy. And there's papers on that to kind of counteract the endogenous heparin-like compounds from their cirrhotic state. And as I said before, numerous papers saying that these patients are still at risk for VT, venous thromboembolism, even in the face of abnormal elevations of their INR or PTT. They can still get clots. We've still seen people clot off the SMA with an INR of 2.5 because of their cirrhotic state. So, acute variceal bleeding, something you guys will see in the ICU occasionally. Overall hospital mortality has decreased from 42% in 1980 to 14% in 2000. And this is mainly because of TIPS and GI interventions. And this is basically related to the severity of portal hypertension, right? It's basically more likely to occur when the hepatic venous pressure gradient is greater than 12 millimeters of mercury. And variceal homeostasis or occlusion of the varices is achieved in greater than 90% of patients, right? Having GI come in and ban those, ligate those. Death is more likely to occur in patients that are active bleeding at the time of endoscopy, patients with a child PUC grade, male greater than 20, or if they have an extrahepatic organ failure. And like we talked about earlier, if they have 2 organ failures, It's about 50% in-hospital mortality, 3 or higher, about 100%. So here's a endoscopy picture of some varices, right? So you should begin your resuscitation early, right? Try to keep them out greater than 65. When these things rupture, they start to have bleeding, because these patients are going to have a large amount of volume coming out. If you've ever gotten to bleeding on a cirrhotic, it's a large amount of pressure in that venous system. You can use colloids as a first-line treatment, as well as your massive transfusion. Use your TEG for helping identify the balance of your resuscitation. There are numerous papers out there talking about factor 7. But use of factor 7 for management of a variceal bleed is not recommended, right? The issue is you have a hole in a vein somewhere, so fix the hole. And then again, transfusion thresholds are similar to what we do for most patients, 7 to 8. So, variceal bleeding medical management. Early administration of terlipressin improves control of bleeding, reduces bleeding mortality and cirrhosis, right? But we don't have terlipressin in the U.S. And then somatostatin analogs like octreotide and vaporitide have been recommended as first-line therapy as well. And so what you can do is you can use vasopressin in lieu of terlipressin, but you have to know that the vasopressin dose is not 0.03 or 0.04. It's much higher. It's 2 to 3 times higher. And there's some pharmacy papers out there that discuss how high you should push it and whether or not it works. As soon as possible, get endoscopy in there to take a look and see if they can ban those. Terlipressin, though we don't have it for FDA approval in the U.S., is the only drug shown to improve survival in a placebo-controlled randomized study. But it's contraindicated to patients that are currently having an MI or have cardiomyopathy or cardiac disease. The somatostatin analogs, octreotide and such, improve bleeding control, but they don't reduce your overall mortality. We talked about band ligation and sclerotherapy. Cyanoacrylate the glue. It's a first-line treatment in bleeding from gastric varices, but not for esophageal. Castro, let's say, what do you do if you have continued bleeding and GI wants you to temporize the patient?
Put a Sizemore Blake tube in.
Perfect. We'll get there in a second. We'll ask you how to do that. TIPS. TIPS is the big procedure that we can have done to decrease these patients' portal pressures, right? Offload the pressure from that system. Basically, what they found is that salvage therapy for uncontrolled variceal bleeding has a 90% bleeding control rate at 1 year, as well as a 1 year survival rate of 52%. You should think TIPS in your mind if you're doing pharmacologic, you have them on some vasopressin, you have them on octreotide, and GI is trying to band it and they're still bleeding. You should think, offload the pressure, get TIPS to decrease that portal system pressure. There was a randomized controlled study that showed early TIPS performed in 24 to 48 hours of admission to vasoactive drugs with endoscopic therapy in patients who were at a high risk of failure. Those were patients with child C or child B with active bleeding. And it basically showed that TIPS showed a significant reduction in treatment failure 1 year, which is what we were talking about before, as well as 1 year mortality was down to 14%. There was no differences in encephalopathy, right? That's usually a board question when you talk about portosystemic shunts, right? Atrial cable shunts, things like that, that those patients, when you did those open procedures to offload that system, they would get hepatic encephalopathy. So TIPS, basically, nice little diagram here showing our IR colleagues cannulating the jugular vein, going through and basically making a connection there to offload the pressure from the portal vein to the hepatic veins with a covered stent. And that will help decrease that portal pressure and decrease the risk of all those varices. All right. So we'll ask Dr. Castro that in a second. All right, so Blakemore and Linton tubes, place those in patients with hemodynamic instability. Basically, it's a bridge, right? It's the Reboa of the esophagus. You put it in, it's basically a bunch of 2 balloons, you blow them up, and you are basically tamponading the bleeding until you can definitively give them a TIPS or get GI there to band those areas. So how do you put it in, Castro?
You insert it in the nose. You put it all the way down, aspirating from the gastric content opening on the balloon until you get gastric contents. Then you inflate the gastric balloon and then inflate the esophageal balloon.
So typically, you'll inflate the gastric balloon or check an X-ray just to make sure in the proper location. You can even put contrast in there. You inflate it and then you pull that back, right? That's the whole reason they have a football helmet on it, to provide traction.
It's very important to insufflate the gastric balloon with like 10 cc's and get an X-ray and confirm it's in the stomach.
You don't want to rupture their esophagus. You want to make sure that's in the stomach because you're occluding those varices up by the GE junction.
Well, but also the purpose of the gastric balloon is to hold it in the stomach. And it blows up like this big. And you don't want to do that if it's in the esophagus and blow it up this big because you just blow out their esophagus and kill
So you
the
pull
patient.
that back, you seat it kind of there in the GE junction.
Exactly.
And then from there you begin blowing up your esophageal balloon. To basically then you're set in place, provide lateral tension on everything. And that's secured by that football helmet with some weight on it. It's kind of a lost art. You don't really see many people do that, but occasionally the CCM folks here will have a couple when on rotation that you'll see them do that.
How long can you leave those in?
I've left it in for no more than 24 hours because you should. It's a bridge, right? We have to get
You gotta get
control.
You gotta get them. It's a bridge to get them to a tips or whatever.
Tips are endoscopy, and so it's just basically a life-saving maneuver. So nutritional support, right? Current recommendations are the diet contain a normal amount of protein. We talked about that earlier. And then you can modify that protein amount up or down based on the degree of catabolism, and presence of renal failure. When thinking about hemodialysis or renal replacement therapy, the goal of protein supplementation is preventing a negative nitrogen balance, which Siri will probably talk about in her lectures. Glycogen storage may become impaired and that can predispose the patient to hypoglycemia. Again, right, we always think about thiamine, multivitamins, right, all the routine orders that you don't even think about, but you can give them 100 milligrams of thiamine IV for about 3 to 5 days. Then you have to think about, trace minerals deficiencies, zinc, as well as selenium. We talked about adrenal insufficiency a little bit earlier. You can replace it with steroid therapy, and it's treated just like our normal ICU patients in cirrhotics. So if they have adrenal insufficiency and they're hypotensive, the recommendations are to replace their adrenal insufficiency. If it's not, then there's no benefit. And there's a recent randomized controlled study that showed that routine of administration of hydrocortisone to these cirrhotics didn't improve any outcomes. Right? Infections. Overt signs of infection may be absent, right? These patients are, already physiologically deranged, so you have to keep a high level of suspicion, right? These patients will decompensate so much faster than a standardized ICU patient that if you don't recognize it, they're going to spiral very quickly. They're going to get sick very quickly, and you may not be able to hemodynamically capture them. So use of early broad-spectrum antibiotics, highly recommended. Just, adhere to your goal-directed therapy guidelines for your institution. If they have or are suspected to have SBP, you can give them cefotaximine 2 grams IV TID in addition to your albumin boluses. So renal failure. Besides hepatopulmonary syndrome, this is one of the more interesting things because these patients can go into their own physiology with hepatorenal syndrome. So, as in all patients, avoid nephrotoxic agents if you can. You want to make sure they're not getting too intravascular deplete. So if you do large volume paracentesis, make sure you give them albumin. Don't do it without. You want to replace that proteinaceous fluid that you're removing. And then their renal dysfunction, as you go throughout your careers, you'll notice that the renal dysfunction in a cirrhotic is really underestimated by the creatinine as well as their BUN. Many times they're already volume deplete and kind of like auto-corrected, so to speak, right? They're living at a creatinine of 1.1 or something like that, but really a lot of their fluid is in their abdomen and their ascites or something like that. And so you have to be sure that you're on top of that. And then hepatorenal syndrome, it's a type of prerenal failure that results from intense vasoconstriction of the renal circulation. There's no real identifiable kidney pathology, and it occurs in patients with advanced cirrhosis. And there's two types. Ferries and Flint first reported oliguria in the absence of renal physiologic changes in patients with cirrhosis and ascites back in 1861. That was the first time someone mentioned, like, hey, these people tend to go into renal failure. The term hepatorenal syndrome wasn't really coined until 1939, which basically showed that patients that had biliary surgery were ending up going into ATN, and no one really knew why. It was because they were, cirrhotics that they were doing biliary surgery on, and then they ended up getting pre-renal. And then Copel et al. In the 1960s showed that the kidneys from patients who died from hepatorenal syndrome, they were basically normal functioning when they transplanted those kidneys into patients with chronic uremia. So they were taking kidneys from people who were dying of cirrhosis and putting them into patients who had chronic uremia as transplants, and showing that that kidney was functioning. It was just an issue with like a pre-renal state. All right, so this is kind of a flow chart for a chronology of changes, how you go from non-azotemic cirrhosis, basically that you're going into hepatorenal syndrome. You begin to see decreased mean arterial pressures, you start to get increased plasma renin activity, you start to get increased norepi levels, you get increased systemic vascular resistance, decreased cardiac output. Then from there, as we talked about right at the beginning of the talk, decreased hepatic blood flow, you start to take a hit to your liver, and then from there you get an increased hepatic pressure gradient. Here's a brief image kind of describing that dilatation from the explaining the vasodilators. So diagnosis of this can be pretty difficult. We see a couple a year. And the main part of this treatment in this talk is trying to prevent this, right? You don't want the patient to go in this because, as we'll talk about, the mortality from hepatorenal syndrome type 1 is astronomical. So first step when you're diagnosing this, you have to demonstrate that the patient has a reduced GFR. So, and muscle mass and creatinine is probably reduced in these patients, right? They have a big belly, they're kind of spindly arms and legs, and so they may have a normal serum creatinine concentration in the setting of a very low GFR. That's the first thing you kind of see in these patients. And then the urea synthesized by the liver will probably be reduced due to hepatic insufficiency, right? We're decreasing the function of the liver, the blood flow of the liver. Next, we have to differentiate it from other types of renal failure, right? They did this oliguria, the low sodium urine concentration, urine to plasma osmolality, and ATN can present as with the same findings in cirrhosis. So based on the lack of specific tests, the diagnosis of hepatorenal syndrome is basically a diagnosis of exclusion of all other causes of renal failure in a patient with cirrhosis. So there's a couple major criteria as well as additional criteria. So chronic or acute liver disease with advanced hepatic failure with portal hypertension. We talked about low GFR, creatinine clearance less than 1.5 milligrams per deciliter. The absence of shock, bacterial infection, or other nephrotoxic agents. Now that doesn't mean that you can't have those things concomitantly with it, but when just thinking about, diagnosis of exclusion. Absence of renal fluid loss, and there should be no sustained improvement in renal function following diuretic withdrawal or plasma expansion. So you take off the diuretics, you stop their nephrotoxic agent, and their creatinine numbers and their urine output doesn't improve. That's when you have to start thinking about that. And you have to have proteinuria less than 500 milligrams per deciliter with no ultrasonograph findings of obstructive uropathy or parenchymal disease. So no problem with the kidney, no outlet obstruction. Additional criteria that's not required is low urine volume, low urine sodium, urine osmolality that's greater than plasma, or serum sodium concentration less than 1/3. So there's a couple different types. We mainly talk about type 1 and type 2, right? Type 1 is cirrhosis with rapidly progressing acute renal failure. That's the worst one to have. Type 2, cirrhosis with subacute renal failure. Type 3 is lesser described, but that's cirrhosis with type 1 or 2 hepatorenal syndrome, but it's superimposed on someone who's got chronic kidney disease or kidney parenchymal disease. And then type 4 is that patient that has fulminant liver failure that needs a transplant that has gone into hepatorenal syndrome. So type 1, that's the most severe. And the primary definition is your serum creatinine has to double to a level greater than 2.5 in less than 2 weeks. This type is almost always associated with a predisposing factor, SBP, GI bleed, major surgery, patient has cirrhosis and gets acute hepatitis, or a trauma patient that has bled and become hypotensive. And it also can occur spontaneously. Hepatorenal syndrome occurs in about 25% of patients with SBP. And despite correction or rapid treatment of SBP, this can still occur. The pathology is still going on while you're fixing the SBP. And it's more common in those that have some type of circulatory dysfunction, right? They're either in shock or they have some cardiomyopathy of some nature or diastolic dysfunction. And as I said earlier, it's characterized by a rapid and severe deterioration of liver and circulatory function. And without treatment, this is the worst one, right? The median time of survival is 2 weeks after you see it happening. And so, again, difficult to stop once the train starts rolling, but we want to prevent that. We want to kind of recognize it early, stop all those other predisposing factors. Type 2 hepatorenal syndrome. This is kind of a more moderate, steady, progressive renal failure. The patient has kind of been indolent in the unit. Their serum creatinine doesn't get above 2.5. It doesn't have that rapid exponential upsweep like type 1. It's kind of a true functional renal failure cirrhosis. Like they're losing volume and things like that. They're not just kind of tanking. So basically, they may show signs of liver failure and arterial hypotension, but they're not, ending up on multiple pressors, acutely dying like type 1 hepatorenal syndrome. Basically, these people are guys or girls with severe ascites, and basically they don't respond to diuretics when trying to control their ascites, and have a predisposing event. Mean survival for this is 4 to 6 months, so markedly greater than type 1. And it's, and that's worse than those with non-asymptomatic renal failure. Here's a little graph showing basically cirrhosis with ascites without hepatorenal syndrome. That line up top, you can see someone, their life expectancy in months. And then type 1, you can see it's almost like a reverse, like exponential curve in terms of survivability. So, big treatment. How do we prevent it? Be aware of it. Type 1, big thing, they need a liver transplant. Their liver's failing. It's causing them to go into severe hepatorenal failure. Then those patients, more likely to go into hepatopulmonary syndrome. Give them vasoconstrictors with volume expansion. Again, terlipressin not available in the U.S., but we can use vasopressin at higher doses, 3 times the normal dose. You can do TIPS, right? Or some studies talk about extracorporeal albumin dialysis, which we don't do here, but I believe they do at a couple other centers in the center of the state. Type 2, very similar. Get them to a TIPS. And again, the purpose of the TIPS is to decrease that pressure, and ultimately those patients will need to get to a liver transplant. So, liver transplant, done at the center down the road here. So it's treatment of HRS type 1. And sometimes their post-transplant impairment of GFR may continue, and they may require dialysis, but they're not in that circulatory compromise. And that happens in about 35% of patients. And so when they have hepatorenal syndrome, the transplant surgeons will delay the use of cyclosporin and tacrolimus until the renal function is beginning to recover, usually about 48 to 72 hours, to not cause like a second hit. And then usually their GFR begins to improve in the next 1 to 2 months. So after you do the transplant, usually the neurochemical abnormalities, the hemodynamic lability begins to dissipate by 1 month. The ability to excrete free water and sodium begins to return to normal after you give them a new liver. They're predisposing the patient that gets the transplant to more complications, right? Which makes sense. The patient that just needs a liver transplant versus the patient that needs a liver transplant has a kidney dysfunction that's affecting their systemic circulatory system, they're going to have more complications, right? More ICU days, longer ICU stay, higher mortality. Long-term survival when someone that has hepatorenal syndrome that gets a liver transplant at 3 years is 60%. And just think about that, right? 60%, that's less than someone who's got stage 3B colon cancer. I mean, so it's a really deadly process. Someone who doesn't have hepatorenal syndrome that gets liver transplant, their life expectancy is about 80% in 3 years. So, and many times, if you do have hepatorenal syndrome, require a liver transplant, meet all the parameters, that will allocate you to the top of the list because you need it now, right? Otherwise, you're not going to be around in 3 to 6 months to get it. We have a couple of quick studies where we're just talking about basically volume expansion and what to give. As I said, majority of these studies are from Europe and they're with terlipressin and albumin. Some of the studies are with vasopressin, high dose, ornopressin, levophed, norepinephrine, and midodrine. So to date, there was 11 studies published with treatment involving 134 patients with HRS type 1. And basically, we were looking at positive response rate to any of those above, using vasopressin, terlipressin, omnipressin. And 61% of those patients turned around when giving volume expansion and a vasoconstrictor. So things you think about when having a cirrhotic, right? Do I need to give them some vasoconstriction, and do I need to expand them with albumin? HRS didn't typically recur in most of those patients after the treatment. Then there was a series of 7 studies that looked at type 1 hepatorenal syndrome using just volume expansion alone with dopamine or octreotide or just alone. Some of them looked at VP shunt or peritoneal venous shunting or just receiving nothing. And basically, hepatorenal syndrome or reversal was only seen in 4 out of 137 of those patients. So, big thing takeaway from looking at those 2 bullet points there is vasoconstrictors with volume expansion by plasma does wonders compared to giving them octreotide or dopamine or doing nothing at all. There were 2 studies that were randomized that showed albumin versus albumin and terlipressin, again in Europe, and basically they showed that reversal of hepatorenal syndrome was associated more frequently in patients receiving terlipressin albumin. Again, take-home point, drug of choice. We don't have it, so we can use something in lieu of it, something that's kind of biochemically similar. Vasopressin basically showed that using terlipressin is what we need to do. The dose is progressive, right? So it began at 1.5 milligrams in 4 hours. If the creatinine didn't decrease by 30% in 3 days, then the dose was doubled. And they continued on that until the creatinine came down. The albumin dose, they gave a 1 gram per kilogram bolus, and they followed that by doing 20 to 40 grams per day. And then that number was based on or adjusted by if they were doing removal of ascites and things like that. And basically, what they were looking at was, these people would respond with normalization of their creatinine. In terms of tips in HRS, there's 3 studies. One had 14 patients with hepatorenal syndrome, and 17 of those had additional 17 had refractory ascites. They looked at 3, 6, and 12 month survival, and basically the survival rate was 64%, 50%, 20% respectively. Another study had 7 patients with hepatorenal syndrome type 1, did TIPS, and they showed a decrease in the serum creatinine in 6 out of the 7 patients, with reversal of their hepatorenal syndrome out of 4 of 7. 5 patients survived 1 month, 2 survived 3 months. I'm rattling these numbers off, but you have to think about that. That's how bad that disease process is, that out of those patients that, when it's rare enough that, the numbers are very small, but the survivability is very small unless they get their liver transplant. The other study looked at 13 patients. One was treated with midodrine, octreotide, and albumin. They were treated with midodrine, octreotide, and albumin, and reversal of hepatorenal syndrome was seen in 10 out of 13 patients. But 5 of those 10, they did TIPS. So they did kind of both things. But on the previous slides, we saw that giving them octreotide and midodrine didn't really affect anything. So I think the majority of it is doing that colloid resuscitation and then providing some way to offload that pressure, either by vasoconstriction or decreasing that pressure with the TIPS. We'll talk one slide about Mars. We don't provide that service here, but basically it's a system using dialysis techniques to remove both the hydrosoluble and non-hydrosoluble substances from the plasma. Mars, which is the trademark for extracorporeal albumin dialysis, uses albumin to remove a variety of endogenous substances, as well as albumin-bound toxins from the blood, like bilirubin, bile salts, long-chain fatty acids, and nitric oxide. We know nitric oxide, right, can lead to hepatopulmonary syndrome, and so basically you're dialyzing that off, so to speak. There's 2 other systems that are similar that are being developed. We're not going to talk about those. Those are Prometheus and SPAD. Basically survival rates show 1 month survivability about 41%, 3 months survivability about 34%. So not great once again. But hopefully you're seeing a theme here, vasoconstriction, decreasing pressure, as well as using albumin, using colloid for these patients. Tips for HRS type 2, 2 big studies. One had 9 patients, and basically this showed an was associated with significant decrease in ascites. 5 patients survived greater than 14 months after they got their TIPS. The other study had 14 patients with HRS type 1 and 17 that had HRS type 2. And it basically showed improvement in creatinine and creatinine clearance in all 31 patients. Showed improvement in ascites out of the 24 out of the 31 patients. And 1 year survivability, or 1 year probability of survivability in the patients with HRS type 2 after they got their TIPS was 70%. So if they go into HRS type 2, they have a decent chance of surviving. HRS type 1, we want to prevent that because overall mortality is terrible.
Yeah.
Vasoconstrictors with albumin, right? Our mainstay here. Again, all these studies done with terlipressin. So 3 studies, they had 26 patients with HRS type 2. So HRS type 2 reversal is noted to be about 80%. There is no data on their survival impact, and this treatment appears to be not as effective as for HRS2 as HRS type 1, but still is providing survivability, 80%. So prevention, right? 3 studies looked at what can we do to prevent, and they looked at IV albumin administration in anybody that had cirrhosis and that had spontaneous bacterial peritonitis. They demonstrated a marked reduction in the incidence of HRS type 1 and circulatory dysfunction. There's a 10% incidence in HRS in the albumin group versus 33% in the control, which is huge for such a horrible disease. Mortality was less with albumin, 10% versus 29%. 3-month mortality was less with albumin as well, 22%. an additional study, patients with a high risk of developing SBP and HRS1 were given norfloxacin for primary prophylaxis. And what they saw was, giving them that antibiotic that had a significant decrease in 1 year probability of developing HRS type 1 or even developing SBP. They showed an increase in 3-month and 1 year probability of survival. And patients with acute alcoholic hepatitis, they also then gave those patients pentoxifilmine. It's a TNF inhibitor versus a control. And they showed the rate of developing HRS with 8% with the TNS inhibitor versus 35% with control. Now, a lot of these studies are small, right? Not everybody out there is walking around with cirrhosis. Not everybody is developing HRS, or, a lot of these patients might be non-compliant. They're maybe alcoholic, not poor availability to healthcare, so it's very hard to get follow-up. Takeaway points about multi-system organ misfailure, right? Cirrhotics have ICU and 6-month mortality rates between 41 to 62%. If you go down the line, 1, 2, 3 organ failure systems, 48, 65, 70. Above 3 and above, it's almost 100% because you're combining their other system failure. Most deaths occur within the first week following ICU admission. The main cause being multi-system organ failure or circulatory collapse. Why can't we save these patients? Why in the last 20 years, as I said in the opening slide, has the mortality rate not changed? There's still no efficient artificial liver support system out there, right? We have Mars, which we saw was okay, and there's a cascade of events usually that leads to a vicious cycle that patients with advanced cirrhosis and acute complications, they can't get out. Once they start to get physiologically deranged, they already are to some extent from their liver. Once they start to get further physiologic derangement, it's very hard to get all those things back on track. As you see, the liver affects the lungs, it affects the circulatory system, it affects the kidneys, and then once you kind of get in that spiral, it's hard to get a patient out. Here's a list of references. I know it's very small. Any questions on overview and management of cirrhotic patients, or what we can do to treat them?
Yeah. 2 questions. So for tips, the IR guys, will they take the patient if they're hypotensive at all for tips here?
It depends on the radiologist, but we do have several good radiologists that will actually do it. I know Dr. Asbel has in the past for the unit, just taking them.
Even
if the patient's dying, they have a Blake more to it, he'll take it and he'll do it.
And
I
how
had,
quickly?
Dr. Yang did one for me back in May, or that Russian girl.
So they put the tips in, and then how quickly do you start seeing better changes?
What's going to change the pressure immediately?
Changes the pressure immediately, but they still have physiologic derangement,
Right, yeah. Right.
And they're not hemodynamically captured. So then it's our job, once they decrease the pressure, to try to stop those processes, which
And then maybe
depends how
banding
far
as
gone they
well.
already are.
Yeah.
You know what I mean?
And their cephalopathy is going to get worse when you do a tips too.
Yeah.
Right? And you think about the other shunts that you can do, right, that are always in the app site, those have worse encephalopathy.
Yeah.
So.
We had done with Dr. Marsh. He did one pretty quickly in patients.
Really?
Yeah. He was aggressive. The idea why we don't have the what's it called?
Terlipressin?
Terlipressin here?
I don't know.
Just,
it's just not
cost
FDA
or-
approved.
FDA thing.
Okay.
Yeah, there's another one that they're working on as well that is not FDA approved
Okay.
either, which is really strange since all the data shows that does better.
Then how frequently do you see hepatopulmonary syndrome?
We see, I think, people with hepatorenal syndrome type 2 probably more frequently. And hepatopulmonary syndrome is a syndrome that it doesn't exist unless you think about it. Unless you come in and you think their lungs are getting that VQ mismatch because we're flooding it with blood from the high pressure. You're not going to think that. You just think that they're on there because their trauma patient have contusion, or they're aspirated because they're a general surgery patient. But it's a diagnosis you're not going to rings in your head unless you think of it.
Cool. Thank you for giving me
Thank
that.
you.
It's really good, actually. Albumin, vasopressin.
Exactly, pretty much.
Did you see my email I sent you the other day?
I didn't.
The one about the
Channel.
Can we, and she was dragging on her too, so I was like.
Yeah, man, that was a big
No,
deal
I-
for her.
I was like,
Look at
I
the
don't,
research.
I
It's
don't
not that
remember
bad. Once we figure that out,
beginning and then
think it'll be-
the user went to- So that's why I went.
So would you stop it?
I don't know what I did.
Did I just hit the stop button? No.
You did talk about, you just had a lot of topics.